right. Okay, I think we can get started at least with introduction and then get going if that's okay, Dr. Ott.
Sure.
Welcome everyone to Geriatric Medicine Grand Rounds. I hope you're all doing well and finding joy in these kind of challenging times. It's great to gather together, and we have really a fantastic speaker who many of you have seen before. We keep inviting Dr. Ott back because she teaches us so much about osteoporosis. She is a professor of medicine and metabolism, endocrinology, and nutrition here at the University of Washington. She also is an adjunct professor of orthopedics and sports medicine and radiology, and she's board certified in internal medicine and nephrology. And her specialty and her area of expertise and research is in metabolic bone disease. And she really knows everything that you could possibly know about metabolic bone disease, particularly osteoporosis. And I'm very excited to hear from you again today. Thank you so much.
Okay, well, I'll just take it away and share the screen. Let's see, share screen. And go here. All right, so I'm gonna try. So the title of my talk is The Seductive Short-Term Effects of Osteoporosis Treatments. And I'm really going to focus on that. I have a few other things, new things I want to point out, but we have a lot of studies that people use as evidence for how to treat, but they only last a few years. And let's see. Oh, and I will say I have no conflicts of interest in this talk. And yeah, I'll start off with saying that something that this audience really knows: osteoporosis is common, but it's not simple. And of course, hip fractures are one of the most important reasons that our patients lose their independence. Not only that, the spine fractures that can cause kyphosis are really distressing. They can be painful, but even after the pain gets away, they're disfiguring. The patients don't like the way their body looks anymore. It's hard to move around, and it can get so bad that it decreases their vital capacity in their lungs. It gives heartburn because of the abdominal problems. So of course, we would like to prevent this if we can. And one of the things I start off with is showing what happens when we would look inside the bone. So if we took a cube, this is a cube of trabecular bone from a young normal person and an osteoporotic person, and you can see how much of the structure of the bone you have lost in addition to the volume. And instead of just getting a thinner wall, you get holes altogether and it's not connected anymore. Okay, so we're going to start with just one introduction about the bone density. Is that the bone density definitely does predict the fractures, but what's interesting is age predicts it even more. So if we, for example, look at somebody with fairly bad osteoporosis, the t-score of -3, at age 80, she'd have a 10% chance of getting a fracture in the next 5 years. At that same bone density, when she's 60, it's only about a 1%. And when she's 50, it's not very much different than usual. So at the same bone density, age really increases it. And there's a whole lot of reasons for that, some of which involve falling, but others involve the quality of the bone. And I'm going to come back to that several times. The quality of the bone is something that you can't measure with a bone density test, but it can be responsible. And even if I took even with the same bone density, if I did biomechanical testing on the bone from an older person, it would break more easily than the younger person. Okay, so back to long-term risks. So the duration of the trials is shown here on this graph, just to sort of show how short they are in terms, in comparison with how long it takes to get the osteoporosis. So if we're looking at people who are in their 60s and 70s, the duration of these drugs is really short. And if we don't treat them right when they're at this age, then they haven't even reached the real, what I call age of fracture yet, which is after 75. So we base all of our recommendations on the results of these trials. That's considered grade A evidence. And I agree, that's grade A evidence, but it's only grade A evidence for 3 to 5 years. And what about long-term? And here we have, variable amount of data depending on the drug, but that's what I'm going to go through. It's 2 important questions. What happens if you take it for a long time? And what happens if you stop? So we'll spend time with each one of these drugs, except the last 2 are a little bit too new for us to have a lot of information about that. Okay, so why doesn't this want to go? There we go. But before we get to that, I want to just go through one thing, a problem that I have seen recently. And that's because I've seen guidelines, and for example, the Endocrine Society is starting to say that you should treat people if they have a T-score lower than -2.5 at the hip or spine. And recently they have added in 2 little words, or radius. And there's no evidence that that helps. I really sincerely wonder who got those 2 words put in, or radius, because a T-score does not translate from one body part to another body part. And so let's just look at this graph a minute of the bone density loss from age 20 to 80. You lose about 25% at both your arm and your hip. But you have to remember, T-scores depend on the standard deviation of the young population. And it just happens that the young population at the radius has a narrower standard deviation. So you lose more T-scores, even though you lose the same percentage of bone. It doesn't matter too much when you're young, but by the time you're 80, the average woman has a T-score of -3 at the arm, but only -2 at the hip. And this is what's happening is that I see people who get, for example, a total hip replacement, and somebody's been following her and her T-score is -2 before that, and then afterwards they can't measure the hip anymore, and so they measure the spine and it's gone down to -3. And the clinicians are saying, oh, this is severe osteoporosis all of a sudden. We got to give a bunch of drugs, and she actually hasn't lost anything or has only lost a little bit. So in your patients, you really have to take the radius with a huge grain of salt, and you really have to know that it doesn't mean the same, and you're not gonna, you'll treat way more people. Look, the average 75-year-old has now got osteoporosis. So you would treat half of your 75-year-olds and practically all of your 85-year-olds. So just please beware of that. Okay. So now what I'm going to do is show this kind of my little movies. And I know some of you have seen my little movies before, but to understand what's going on, you need to know a little about bone physiology. So we're going to show what would happen. And here's the players of the bone physiology. We have the stem cells that are going to turn into the osteoblasts. And these are, this little dot is sclerostin, which is being continually released by these cells, which are osteocytes. So the osteocytes are members of the osteoblast family, and you can go from this to this. These are lining cells. They're also specialized members of the osteoblast family. And meanwhile, the osteoclasts, which are related to macrophages, are circulating. And here are the pre-osteoclasts. So what happens is that a crack will happen. And these happen all the time. You step a little funny, you get damage, you have a minor fall. And the osteocytes next to the damaged area will undergo apoptosis. And as they're doing that, they're secreting factors, particularly rank ligand. But they're also secreting, they also stop secreting the sclerostin, allowing the stem cell to react. So here's the factors that are being secreted by those. And it also causes a change in the lining cells. So now we've changed the surface of the bone next to the damaged area. And we've opened up the bone, which is protected by these lining cells, to the circulation so that the pre-osteoclast can actually come in and access the bone. And then we, at the same time, start making some pre-osteoblasts that are going to come back in the future and fill in the cavity. And they make a lot of factors. Okay, so now that's called rank ligand. So the way that denosumab, I'm going to show you why this works, where the drugs work. The denosumab works by blocking the rank ligand here. And so that the pre-osteoclasts can't form into osteoclasts. And that's why denosumab stops you from resorbing bone. Okay, then meanwhile, the osteoclast is going to resorb bone, and it'll, basically clear out the cavity and secrete some really interesting factors. So the osteoclast will actually release factors from the middle of the bone that were laid down previously. And one of those is called TGF. And it comes around to this top side of the osteoclast. And then the osteoclast will secrete something called Wnt, which goes to the stem cells and the osteoblast and starts differentiating and proliferating these cells. So you're setting up the formation of bone to repair it while you're dissolving the bone. Now, one of the things that happens with the osteoblast is how estrogen works, is it controls the life cycle of the osteoclast. It usually takes about 2 weeks, but with estrogen, it'll take longer. So you're going to dissolve more bone. And that's why postmenopausal women have more bone loss. It comes down to the osteoclast and the estrogen. Okay, so it's undergoing apoptosis. And now all the osteoblasts make something called osteoprotegerin, which will stop the osteoclasts from dissolving. So it's kind of putting a brake on the whole process. And then the osteoblasts are now going to do their job to fill it in. So the stem cells divide, the osteoclasts proliferate, got a lot of growth factors in there. And they eventually line up and start secreting collagen. And some of them stay behind. And you gradually fill it up. And some of them turn into lining cells. And then the ones that stay behind turn into osteocytes, which start secreting sclerostin again to get things back to normal. And it gradually starts getting filled in with mineral. The timing of this is about 6 to 9 months to fill in the cavity, and about up to 3 years for the mineral to actually deposit into the bone. Okay. So now we're going to step back. Instead of looking at the cells, we're going to look at a piece of bone. So this would be about as much as you see on a microscope slide. And we're going to show this whole process as it moves across the surface of the bone. So there's the crack, there's the osteoclasts, the osteoblasts coming in, the osteoid, which we color red, and the brand new bone, which is light green. And as it fills in, the light green starts turning into darker green, which is representing the mineral coming in. So now we're going to step back even further and look at what happens to a normal person. So if we could, go in and look at the bone, and I color the bone green just because that's the color it is when we dye it in our lab. And the brand new osteoid, which is not yet mineralized bone, is red. And you're going to see holes, you're going to see places that are dissolving away and then filling in again on the bone. So this is a very compressed, it's about 3 years worth. So that's the kind of image and mental image I'd like you to have about what's going on inside the bone. Is, the bone is constantly moving, it's constantly repairing itself. That keeps the bone fresh. It keeps it more pliable, and it keeps it stronger. Now, what happens with menopause? So you remember that the osteoclasts are going to live a little longer. So it's a little bit subtle, but if you have it more osteoclasts, you're going to perforate the bone. So you're going to see that you dissolve from both sides, and then you can actually get a hole in the bone. Oops, wrong thing. There we go. So you can see after a couple of months of lack of estrogen, now we have holes, perforations in the bone. And actually this has been demonstrated using very high resolution MRI that can see the trabecular network. And within just 2 years in normal women going through menopause, you're starting to see the architecture of the bone get destroyed. And that, of course, ultimately leads to osteoporosis. So if we give back estrogen, you're really going to kind of put the process back to the way it was premenopausally. And this would be what would happen if we treat with estrogen or with SERMs, such as raloxifene. And the way this one goes is that for the first 6 months, we just have bone turnover going on. And then the little stars mean that you've started treating them, and you'll see what happens. But the effects are subtle. Oops, I keep doing that. There. Okay. So now we give the medicine. And you're really just not dissolving as deep a cavity. So it doesn't look all that different, but what we have here is actually the lack of perforations. So the reason that this helps is that we are, no longer perforating the bone and losing the architecture of the bone. And so here is some data about long-term use of estrogen. And, I think most of the geriatricians are not seeing women within 5 years of the menopause. And so that's really when it's safe to start estrogen. And once you're more than a decade after menopause, there's too many cardiovascular risks from starting estrogen in an older woman. So we're not going to recommend that you start it. However, for other doctors who would start the estrogen at the time of menopause, then it's actually an excellent drug for preventing fractures. And this is older data because it was prior to the Women's Health Initiative, when there were a lot of women who were taking estrogen, and they recruited almost 10,000 women who were older than 65 at the onset of the study, and the mean duration of estrogen at the baseline was 24 years. So here's the baseline, and now they're following the estrogen users and the non-users. So by the time they followed them for 10 years, these women had been using estrogen for 34 years. And the entire time, they have a much lower fracture rate. And by the time they get into their 80s, we're looking at about a third to a half as many hip fractures in women who've used estrogen. We don't have that kind of long-term data with raloxifene, but since it works by activating the estrogen receptors on the bone, it's probably going to be similar. Raloxifene is a little weaker than estrogen, so we would like to have a stronger SERM, but at least it doesn't have any long-term negative effects. Okay. And what happens if you stop estrogen? Well, we do have data about this from the Women's Health Initiative. And so there's two groups, one that just got estrogen on this side and one that got estrogen with medroxyprogesterone acetate. And they stopped it right at time 0. And they followed the ones who previously had been on the estrogen or in the dotted lines. And if you had medroxyprogesterone, then you had a slightly lower fracture risk for the first 3 years after you stopped. And then it gradually came up so that the fracture risk was about the same as the women who had not taken any estrogen. And in the ones who got estrogen only because they had a hysterectomy, you see a little bit better results. And you can see that even after you stop, 5 years after you stop, the fracture rate is still lower than in the women who'd been given the placebo. And then there's observational studies that look at women who've previously taken estrogen. And the effect actually does wear off. So that even with this group who only took estrogen, by 10 years after they stopped, there's no longer any protection. But there certainly is no rebound or no risk. And as you could tell, this is what's going to happen with some of our other drugs. So now we'll go to bisphosphonates, which are still our cornerstone, and we are going to use them a lot. But this is how they work. So we're going to go back to our little diagram to show how it works. And there will be little dots coming in showing the alendronate or a bisphosphonate after 6 months. So that's the normal turnover. And then here comes the medicine. And it completely stops the bone resorption. And since there's no bone resorption, it almost completely stops the bone formation. And over time, the mineral will deposit in the bone. So that's actually what's happening. And I mean, I can say an anecdote. One of the endocrine fellows who'd been, very interested in this, and I asked, what happens to the bone formation with bisphosphonates? And she said, well, never thought of it before. I guess it goes up because you make more, your bone density goes up. So that's really a wide belief that somehow, these drugs are creating new bone, making the bone density go up, and it's not what's happening. You're freezing the bone, and that in the first 3 years, you're not getting any perforations. And so during the first few years of these drugs, your bone is actually a little stronger, but you can't repair this damage anymore. That's what I was showing in the very first set of movies. So they accumulate, and we do have data about that. And just to emphasize that, yes, the bisphosphonates make your bone density go up, but they don't measure the intrinsic toughness of the bone. They can't tell how brittle it is. They can't tell if there's cracks. They can't tell if it can repair damage. And if you like data, this is data showing the bone formation rate measured by the mineralizing surface. And on all these dots, each dot's a single study of normal people up in here, normal premenopausal women, postmenopausal women. Women with osteoporosis have a little more variability, women treated with bisphosphonates are very low. And in the clinical trials, you're seeing about a 90% decrease in the formation, which is different than a lot of other medications. I'll just point out, here's teriparatide going up, fluoride going up, but we don't use that. And raloxifene and estrogen make your bone formation go down a little bit, but not down to these severe levels. And denosumab is actually even more than bisphosphonates. This is what the cracks look like when we look at them under the microscope and stain them. So they're small cracks. You can't see them on an X-ray, but they are damaging the quality of the bone. And this was a study that was looking, it was definitely observational and a small study, but the women had been taking bisphosphonates from 1 to 17 years. And they measured the strength as well as the number of cracks. And the strength of the bone for the first 5 years to 7 years was actually higher. But then with duration, it went down. Meanwhile, the cracks went up significantly, and they went up steadily the whole time. So you're getting two effects physiologically. One is you're stopping the high resorption rate. And so you're not perforating the bone anymore. And you do get a very small amount of new bone because you fill in the areas that were filling bone in when you started the medicine will continue to fill in. But after a while, that benefit is basically overridden by the number of cracks.
We had a question that came in
Right.
about bisphosphonates and fractures. If this, if these changes that bisphosphonates cause should lead you to stop bisphosphonates if someone has a fracture.
So that's a great question because it's leading right up to my next couple of slides. So this is, again, just showing you the cracks in a different study, how the number of cracks is going to go up. And these are only seen on bone biopsies, which, of course, we can't go getting bone biopsies on our patients in the clinic. Just to remind you again, fossil bones have high bone density. So that bone that we see embedded in this wall here is the same structure as it was millions of years ago. It didn't get bigger, but it certainly is denser because the mineral went in. And that's what happens to the bone with bisphosphonates. The mineral goes in, so the mineralization density goes up. And when you have a lot of mineral, it fractures differently. So it's a little harder to break it, but when it breaks in this clean snap. And so I couldn't help but noticing one day when we went to see some petrified logs, the sharp way this log broke. So this log did not break while it was a living tree. It broke when it was in the ground and there was an earthquake. Here's what happens when the living tree breaks. You see, it's a different kind of fracture. And so here's what happens to bone. So if you just have weak bone and you get what we call a typical fracture, it's breaking like this. It's comminuted. It's got angles and sharp edges. There's a kind of fracture that happens with bisphosphonates. It's atypical. And look at this very, very sharp transverse line. That's the characteristic feature of these fractures. And so the bone is more brittle. And here's another example of a patient who you could see that there was something going on here before it broke. This is a harbinger of a fracture, these periosteal reactions. The periosteum can still form bone, even it doesn't need to have prior resorption. So you'll try to get it making a callus, but it's not sufficient. And with just a little bit of trauma, this patient was getting dressed on her way to my appointment in my clinic, and she ended up in the emergency room with this sharp fracture. And the incidence of these kind of fractures goes up with age. And this was a study that we did using data from South California Kaiser. And they have a bone program there. So they're looking at all the x-rays of any femur fractures. And the atypical appearance was extremely rare if you weren't taking bisphosphonates. It was just like less than 1 in 100,000. Even short term, you started seeing a few, but it really starts going up after 5 years, and it becomes significantly different. And by 10 years, we're seeing about 1 in 1,000 women who've been on bisphosphonates are going to get an atypical femur fracture. And I have to say, a lot of my colleagues didn't really believe the data. They said we weren't calculating the incidence right, or that we weren't really looking at the x-rays right, all sorts of things. But 2 other studies have now been published since then. This one's from Northern California. And the results are not only similar, they're even a little worse. And they were seeing almost 2 in 1,000 women after 10 years. And here's one that was published just last year by a group who showed that the rates really went up, and they were seeing the same pattern. And so I think it's really been definitely shown, and we've seen it in European studies, that these fractures are related to long-term use of bisphosphonate. The, I think, more important question, which is not yet answered yet. Well, what about typical fractures? We know that atypical fractures occur more often, but they're still relatively unusual. You know, 1 in 1,000 is not rare. I mean, I've already got 70 patients with it, but it's not like really common. But typical fractures are very common. And this is, we have to look at this with observational studies. There's no way that you can do a trial for 10 to 15 years of these drugs. And so one of the observational studies was actually done by some of our epidemiologists here. And they are looking at the incidence of any clinical fracture, and they adjusted it for bone density and age and all of the risk factors that they accumulated in the Women's Health Initiative to see what happened. And in duration of 3 to 5 years, they didn't have any benefit, actually. And at 10 to 13 years, it looked like there were a few more. And this is compared to 2 years, okay? So just to make it clear, that meant at 2 years, from 2 years to 6 years, there was a reduction. So if you compared it to women who weren't taking bisphosphonates, there was a definite reduction in the number of fractures. But if we compared the long-term use to the short-term use, then you were starting to see more fractures again. So it looked like you got a benefit at first, but then it started reversing. So before I say recommendations, I have to say what happens when you stop then. So what if you stop bisphosphonates after 5 years? And that's been studied in a randomized trial called the FLEX study. And the women were part of the original intervention trial. So during the first 5 years, these women had all been on alendronate. And we're looking at, oh, I put the wrong slide there. No. First, I didn't. We were looking at the formation markers and NTX, that's the resorption marker. So you stop resorbing bone and then you take the drug. But when you stop and switch women to either alendronate or placebo, for the next 5 years, this value stayed really low. So this is the NTX. That's the measure of whether you're dissolving your bone. And even though you're not taking the drug for 5 years, it's staying low. So you don't need to keep taking it. And what happened to the fracture rates? So they used actually 2 different doses of alendronate, but the placebo is in green here. So at baseline now, remember, everybody has taken it for 5 years. So you're going to stop. And what happened to the fracture rates? Well, they're the same for the next 5 years. So it doesn't do you any good to keep taking them. So once you've taken the bisphosphonates for 5 years, you can safely stop. And in fact, I'm arguing that you should stop at 5 years because it's not effective anymore. You know, if it were effective, then the ones on the alendronate would have a lower fracture rate than the ones on the placebo. So some people said, well, maybe that's true for the whole group, but what about the ones who really were at the high risk? What about the ones who really had osteoporosis? So these results, by the way, are the ones that you can only find from the FDA report. They didn't get published in the journal articles, but the FDA, I think, had the least biased way of looking at it. And this is only the women who had a T-score of less than 2.5 at the total hip. So these are the high-risk women. And they had more fractures, but it didn't matter. Again, the green line here is just the same as the other 2 lines. So I'm saying that I'm spending a lot of time on this because I've heard it over and over and over again that we should use bisphosphonates for 10 years in the women who are at a high risk. And they misquote this study. And so I'm just showing you the actual data. And if you can burn that into your brains, then you won't give your women bisphosphonates for more than 5 years. And although it hasn't been studied in men, all the other studies in men show that their bone works the same way with bisphosphonates as with women. So I really think that you should stop that. And then you would really also reduce the chance of any of the atypical fractures. Okay, so how am I doing here on time? Okay. All right, so now we're gonna just briefly mention teriparatide. So that's the first anabolic drug. And we're gonna show the same kind of movie as before, but this time we're gonna start giving teriparatide at 6 months. Oops, I'll not learn here. Okay, so here we have the bone, and you have to watch quickly. You're actually making bone. But you're also really resorbing bone. So all this new cavities have been made, but you form more of it than you resorb. So all this light green color is the brand new bone that you formed. And the color actually is representative of the fact that the new bone isn't very dense. It doesn't have much mineral in it yet because that takes 3 years. And this is only the first year. If you then give something to stop the bone resorption, all of this will fill in and the bone density and the strength actually gets even better. So why don't we have we don't have longer term risks with teriparatide because the FDA put a black box warning on it due to the fact that they had cancer in the rats. Now that was more than 20 years ago, and there's really good evidence that it hasn't been seen in humans. But the other reason that we don't keep using it is that it loses its potency. And so after 18 months, you actually are no longer forming much new bone. So it really isn't worth it to give it. It doesn't work anymore. And the other point I want to make about this is that you're forming a lot of new bone, but you're also resorbing a lot of bone. And so in normal people, or people whose only problem is osteoporosis, you're going to end up with a net benefit. But if you have some reason that you can't really form the bone very well, and the prime example is end-stage liver disease, it can work backwards. You'll be able to resorb the bone just fine, but you don't have the protein to form the new bone. And so this treatment has a double-edged sword to it. That you can, if you're not careful, you can actually make the bone weaker. What happens when so there is no long-term data, but we don't use it long-term anyway, because it only works for a year. What happens when you stop is that the bone resorption keeps going for a while. And so this is just one of several studies that shows that the green was they gave it for a year and then stopped, and you start losing it again. And at the hip, you get a little bit, but it starts going down again. So it's kind of a shame that if you give this drug, which is pretty complicated to give, and you build all this new bone, and then the patient is not followed up with something to consolidate the bone, then they're back where they're started from. And you'll get a very brief benefit on their fracture rate, but it will dissolve. And I see that too often, that the people will start this medicine without follow through. And the patients don't even realize it. They can't just stop it. However, you can give an anti-resorptive drug. So raloxifene is actually my first choice, but bisphosphonates would also work. And this happened to be the study of raloxifene, where the bone, you didn't get the bone loss with that. And with the hip, especially the hip, the bone density went up with raloxifene when it went down if you stopped it. So take home message there is, if you're going to use this drug, which, when you use it, when somebody has really got severe disease, when they've had complications of bisphosphonate, in some of our pelvic fracture patients, if they are generally otherwise kind of healthy, I like to use it. And we've used it, I can't remember my oldest patient, I think 95. So you guys can be using this medication if you are careful who you use it with. But you're only going to use it for, 1.5 to 2 years. And then you're going to have to be careful to follow up, because when you stop, you'll lose it all. Okay, now we're going to switch to Denosumab. And same movie now. So here we go, and we give one shot now. And then we keep giving it, and nothing much changes. So we decide to stop. And we get a very high resorption rate that causes a lot of perforations. Okay. So let's talk about Denosumab. It does increase the bone density, and it does reduce clinical fractures during the time that they gave it. It stops bone resorption and completely stops bone formation rate. So you're just not forming any new bone, and you're not resorbing any new bone, and you can't repair any of the micro damage. You're getting the rate of atypical fractures. We don't have enough data, because this now depends on observational data. It hasn't been used for enough people in long enough time to know, but even within the clinical trials, you're seeing atypical fractures and jaw osteonecrosis at about the same or even greater rate than with the bisphosphonates. So there's a physiologic reason to suppose that it's going to make the bone brittle in a long time, just the way it would with bisphosphonates. But the most important thing we'll talk about is what happens if you decide to stop. This is where it's completely different. Remember, when you stop bisphosphonates, nothing much happens, nothing bad happens. But when you stop this, you really lose a lot, and you lose it very rapidly. So this was the first trial, data from the first trial, and this was from one of the centers where they had a dozen patients. And the red line is people who started getting denosumab during the randomized part of the trial, which was years 1 to 3. And you can see, actually, you guys can see my marker?
Yes, yes, we can.
Okay. So you can see that the bone density goes up at the hip. And in the placebo group, the blue line had placebo during the first 3 years, and the bone density went down a little bit. And then at 3 years, it became open label. So everybody got it. And so now the placebo group catches up with the other group. And they extended this for 10 years. So now the red group has been on it for 10 years. The blue group has been on it for 7 years, and they discontinued it. And within a year, and actually would be within 6 months, because this was when they got the shot. So the first 6 months, they were still on, basically it was still active. So within 6 months, you went way down lower than baseline. So they gained 8% and lost 12%. This is an extremely rapid rate of bone loss. And the same thing's happening in your spine. So you're not just drifting down at the rate that you would see with aging. You're rapidly resorbing the bone. This is just a graph showing what happened in the spine, the femoral neck, and the total hip. Okay, and the consequence of that can be multiple vertebral compression fractures. So this is just an example of women who'd been treated with denosumab from the literature. And one of the first case reports of this, it was 5 years ago now. And you can see that within 6 months, she got 1, 2, 3, 4, 5 compression fractures. And here's one of my patients who didn't have the complications of breast cancer or anything. She just was a woman with osteoporosis. And all she did was skip a dose. And here she is beforehand. Here she is 1, 2, 3, 4, 5, 6, 7 fractures. And this was before a lot of the doctors realized denosumab could do this, and they thought that she had cancer or something like that. And no, she just had skipped it, because these fractures could start happening. That bone loss is really rapid, and you'll start seeing them after about 8 or 9 months. So then they went back and looked at the subjects from the studies who had dropped out. And when they looked at the ones who had dropped out of denosumab, they had a higher rate off treatment than if they dropped off of the placebo. And this was a significantly higher rate. So the clinical features of these women who get spontaneous vertebral fractures after they stop. In one survey of this, they were about 66 years old, but there was wide range. They'd been on it for about a year. No, the fractures started about 11 months after the last injection. So you remember that the first 6 months after the last injection is when the denosumab is still in your system. It's an antibody. So that means that the fractures started about 6 months after the denosumab had worn off on average. And interestingly, 12 of the women who had vertebroplasties had 58 new fractures in the following days. Okay, so that's 5 per patient. And here's some more information. The risk factors, if you had prevalent vertebral fractures, the longer the duration of treatment, the longer duration off therapy. The ones who gained the most seemed to lose the most. If they were a little younger, if they had vertebroplasty. And there's a question whether prior bisphosphonate treatment would prevent that. And that's still a little bit of a question. So this is really new information, is why does this happen? And so some studies have shown that, and if you remember the very first slide, the pre-osteoclasts are going to form when you have rank ligand into an osteoclast. And then when the osteoclast has done its job dissolving the bone after a couple of weeks, it undergoes apoptosis. And if you don't have rank ligand, they don't undergo apoptosis, they undergo fission. And they break down into little cells that have, now these cells have all the proteins that the osteoclasts have. So genetically, they are still like osteoclasts, but they only have one cell. And so they circulate. So they're called fission cells, and now they got a new name. They're called osteomorphs. And these have never been described before, but they've been shown in humans to accumulate with duration of denosumab therapy. And what happens when the rank ligand returns is they rapidly fuse and they're all good to go. So in no time at all of these cells turn into osteoclasts. And so we actually have a physiologic reason why we get this rapid bone loss. So I'm just going to skip through some of these because we're running out of time, but I think I have shown what can you do about it? Well, then you're in a bind. So you can give bisphosphonates, which is the second strongest drug we have for anti-resorption. Even giving bisphosphonates, you're going to get, in one randomized study, you're going to get a loss of about, depending on how long you took it. If you've taken it more than 3 or 4 years, you're going to get a loss of about 5% when you stop, even when you treat it with zoledronate. And the zoledronate doesn't last as long. You have to sometimes give 2 or 3 courses of it because these osteomorphs seem to act for a while. And this is an area that's still new enough that we wish we had even more data that we don't have. So the response to the drug company is, well, yeah, just keep giving it, keep giving it. So they have to come in every 6 months, strictly. And I suppose you could keep giving it, especially if you're very old, and hope that you'll die of something else before you have to stop the denosumab. But there is a side effect that happens if you start getting kidney problems. And that as you get worsening kidney failure, you get a high incidence of serious, and by hypocalcemia, and by that I mean seizures, Lindra spasm, arrhythmias, tetany, in the hospital with ICU drips of calcium. And so you don't want to use this in chronic kidney disease. And a lot of our older people are kind of going into chronic kidney disease. So giving it lifelong, to me, isn't a very good solution. And, something happens soon. They go into a nursing home. They don't come back to get their shot. It's going to be really hard to imagine every 6 months for the rest of your life. And so you're really stuck when you start this drug. And actually, my personal practice, we've stopped using it. So that's denosumab. Oh, this is just 6 of 8 patients with CKD5 had severe hypocalcemia. It also, one patient with kidney disease developed severe vascular calcification within 10 months because of all the calcium that they had to give him to prevent the hypocalcemia. So it's you get yourself in a box. And I guess I have 2 more slides about romosozumab. That's actually the brand new drug, and the way we're going to have a movie for Romo yet, but it has all the benefits of the teriparatide in terms of forming bone, but you also don't resorb, you actually inhibit bone resorption. So Romo works really well. It only works for about a year in terms of how long is forming bone. The bone density keeps going up a little bit as it gets more mineralized, but we only use it for a year because it only stimulates the bone formation for a year. And if you stop, you do lose. So this is another one, just like teriparatide. If you want to maintain your gain, you need to follow it with anti-resorptive drug. And when we use Romo, we've been following it with alendronate most of the time. Okay. And here's the P1NP, the marker bone formation goes way up. Actually, it only stays up for about 6 months and then it starts coming down as a group, but there's some who are still up after a year. So we give it for a year. But look at what happens to the resorption. Romo actually decreases the resorption rate and it stays low for the whole time you're on it. And this was just showing what happens if you give it and then you follow it with alendronate. So this is Romo and this is Romo followed by alendronate. Then you maintain your gain. Okay. So there's my bottom line. For each medicine you start, you should have a plan for the duration and for the follow-up. And it's critical for the injectables. It's actually pretty important for the bisphosphonate. And you're mostly going to be using bisphosphonates in these patients. And I think for the geriatric patients, a lot of times a single dose of alendronate is really a perfect drug. But the oral is fine if they can take it and don't have trouble with memory. But you only need to give it for 5 years. So you maybe only need to give 2 or 3 doses of the alendronate, and you can space it out for 2 or 3 years. For the ones that you do decide to give the teriparatide, you need to follow it up with an anti-resorptive. And right now, I'm not recommending Denosumab in anybody. And I think that's the, oh, there we go, that's the end. So I didn't leave very much time for questions, but I'm happy to stay on if there are any.
Thanks so much. If anyone has questions, feel free to put them in the chat or certainly unmute if you have a question.
Sorry, did someone else have a question? This is May.
Go ahead.
I have one about raloxifene then. So do you feel that for our younger, we don't see patients, you're right, until they're in their mid 70s. So would there be a role for raloxifene in those women who are hesitant to take a bisphosphonate and have a life expectancy of 20 to 30 years, which some of them do?
No, actually, I didn't spend quite as much time on raloxifene because we don't have any problems with long-term raloxifene. And we don't have any problems with stopping it. So it's really safe in those 2 things. The main problem with raloxifene is it's not quite as effective at hip fracture. And so in the geriatric population, more often they're at risk for hip fracture. So then I would go with the stronger drug, but it's a second choice if somebody doesn't want to take a bisphosphonate, and it still does prevent the spine fractures almost as well as bisphosphonate. And in women who have a lower bone density at the spine than the hip, which is really pretty common, then I almost always use raloxifene. And the only thing you have to worry about is it does increase coagulation a little bit. And that's the same as estrogen. So you're going to about double the risk of thrombophlebitis. And if you have serious cardiovascular disease and have a high risk for stroke, you're probably not going to want to use it because of that. And if we were using estrogen, we could give it transdermally, and then the risk of stroke is basically no different than it is in women who don't take estrogen. But we haven't got a transdermal serum. And if I could have a wish right now, professional wish, it would be a transdermal lasofoxifene, because that one actually reduced hip fracture, MI, spine fracture, and breast cancer. And the only problem left was the blood clots, and then we could get rid of that. So I don't know if anybody's working on it, but definitely it's good for your, and you know, you can start it at any age though. There's, as long as you don't have serious cardiovascular disease, you can start raloxifene at any age.
We have a question about what to do with our patients already on Denosumab. Should we be switching them to Bisphosphonates, or what do you do when it's already happened, and how much time might you have to make that switch?
No, that's the one show that I showed you was giving Cellular. So what I've been doing in people whose other doctors started the Denosumab on them is switching them. It depends a little on how long they've been on it. If it's only been 1 or 2 years, you can get away with oral alendronate, but I tend to use the IV because it's more definite. They're still going to lose bone, and the timing of it is not clear. Now, one study did this very complicated. They randomized into starting right away, which is 6 months after the last shot. Then one group had 8 months after the last shot. One group, they followed the NTX and did it when the NTX started going up. And unfortunately, the bone was lost in every way they did it. So so this is what I personally am doing now, is I wait 7.5 months after their last shot. And then I give 1 dose of zoledronic acid. And then about 6 months later, I follow the urine NTX to make sure it stays down, because sometimes it pops back up again. And if it does, then I give a second dose. Okay, so that's pretty much it. Your other choice is just to, you know, if you just stop that, then they'll lose. So that's not such a really good choice. Okay, I have a few people who have CKD. And so you probably have quite a few of those too, because they're more common in older people. So if they have CKD and somebody has given Denosumab, you are really in a box. So what I've been doing, I've been using zoledronate anyway, but I've been doing tiny doses. So I'll give, like, depending on the degree of renal function, 2 to 3 milligrams of zoledronate, and then see how they do. Maybe repeat it. Okay, and I also give it trickle it in, because the problem with the kidney is if you give it too rapidly, then you're damaging the renal tubular cells. So if you have a little CKD, which a lot of your patients are going to have CKD3, instead of giving it over 15 minutes, I give it over like 45 minutes. I give it half an hour for my ordinary patients and 45 minutes for my renal patients, to avoid damaging your tubules.
Thanks so much. I know some folks have to go, but there was one more question for those who can stay on. Dr. Phelan is wondering if there are any caveats for the treatment of older men with osteoporosis.
Well, most of the stuff about the bisphosphonates and Denosumab apply equally to the men as to the women. We don't have SERMs for men, so we're kind of more limited. If we're going to follow up, for example, if you give them teriparatide, you can't follow up with raloxifene in the man. You have to use a bisphosphonate in the man. And in men, I think androgen, we don't have the limitation. In women, we can't start estrogen, but in men, we could start androgen, we could start testosterone in older men. And in many times that, if they're hypogonadal, that would be my first go-to medicine to treat an elderly man with osteoporosis. I always check their testosterone, and if it's, you all know that some of them are going to be low, not necessarily low, then androgens are good as long as there's no problem with their prostate.
Great, thank you so much. I appreciate you staying after the hour, and thank you everyone for your questions, but especially thank you, Dr. Ott, for coming back and teaching us all about osteoporosis. This is so helpful.
Maybe next year we can do it in person.
I hope so.
Okay.
All right. Have a good weekend, everyone. Enjoy the holiday on Monday.
Thank you.